So, first of all, thank you very much to the organizers for having me as speaker today. It's a pleasure to be here. It's great to see so many young faces and the future of hopefully the future of the American Thyroid Association. I'm not going to talk about my career because my career path is completely crazy. I trained in Brazil and I moved to, I trained in the United States and then I moved back to Brazil and then I moved back to the United States. So this really, I don't think that's going to be applicable to most of you. And so the first thing is, if you're a fellow and you're into a 2-year program, which is most of the programs are, I think that you should look at your fellowship as an opportunity, not only an opportunity to get good training, but an opportunity to set up your career, because you will see as I go along, if you don't take the right steps, or at least you're not pointed towards the right direction during your fellowship, it just gets harder and harder, at least if you want to follow the academic career. And one of the important things during your fellowship is to identify a mentor. This is really not easy. This is probably the toughest thing you guys have to do. It doesn't necessarily have to be the person that's going to guide you through the next 10, 15, 20 years, but at least it has to be somebody that's going to help you or assist you choosing the right track, the right step, to take the right steps at the right time. So having a mentor is very important. And I see fellows that are just going through the fellowship. They're so busy doing all the work that they have to do. And the last thing they think about is identifying a mentor. And I think that's very critical. Even if in the beginning, if you don't have one person, but if you can talk to 2 or 3 different individuals and get advice from them, and you should look at role models for you. You should think, well, what I would like to be in the next 5 or 10 years, and identify somebody in your division, a faculty member, who is, playing a role that really looks attractive to you. And in that way, this mentor or this set of mentors that you're going to elect will decide or will help you, make up your mind in what kind of academic role you want to play. And from a large perspective, you can be, even in the academic setting, you can be a full-time clinician, you can be in a clinician educator track, or you can be a physician scientist. Those are 3 types of individuals that you're going to find in most divisions of endocrinology throughout the country. And so let's talk about the first one, which is the full-time clinician. I'm going to go back a little bit, but let's say you did not start as you don't have papers, you don't have preliminary data, you couldn't find a mentor to help you to the fellowship. You're going to start as a full-time clinician. That's also a good opportunity. Let's say you're finishing up your fellowship today and you didn't take the steps that I'm going to talk about in a minute. You can start as a full-time clinician, and the beauty of this is that the full-time clinician can, with time, migrate to the clinician educator time. And why do I say that? Because as you will see, a clinician educator time needs some protected time, and the availability of spots for a clinician educator might not be there, but most divisions in the country are ready to hire full-time clinicians. So that's an easy opening, an easy door for you to become a faculty in a division that you can later transition to the other paths, if you will. On the other hand, for you to go into a physician scientist track, you really need to have worked a little bit during your fellowship in order to prepare for obtaining what is known as career development awards. So basically, these career development awards that you can get from the VA, you can get from the NIH, you can get from different endocrine societies, diabetes societies, for example, will basically protect your time. So you will have time set aside from your clinical activity. This is what these folks don't have. as a physician scientist, you will have a big chunk of your time protected from a grant that's going to allow you to grow into your career and basically doing research. It will have clinical activity as well, but not as much as these guys here. But in order to succeed as a physician scientist and have this time of yours protected, you need to have grants. So it is not trivial to obtain this career development awards. This is a very competitive track. And basically, for those individuals that really want to pursue that track, it's very advisable, recommendable that you get a third year of your fellowship. And why is that? Because to obtain this, most of these awards are based on work that you already did during your fellowship. So during your fellowship, supposedly the ideal candidate will have identified a mentor or a couple of mentors, and working closely with those mentors, they would have produced preliminary data. They will have published maybe a paper, maybe a case report. But the most important thing is we'll have some preliminary data, and we'll go to the NIH, or we'll go to the VA, or we'll go to the Endocrine Society and say, listen, I was a great fellow, I have a mentor, we have ideas, this is the work I already did. Now I want to be a faculty, and I want to have a big chunk of my time protected. So basically, this is, it's very rewarding to go into that track, but you need to take the right steps. If you didn't prepare all those steps through your fellowship, but you still want to be in academic medicine, academic endocrinology, you have to take the other route. So, let's say you succeed as obtaining your K award series, your career development award. What are you going to be looking at in your future? How is going to be your life as an academic endocrinologist? Well, basically, the K series awards, they are awards that are given that protect 70% of your time, but they last only for between 4 and 5 years. So it means that during your junior years as a faculty, during those first 4 or 5 years, you will have to be producing more studies, publishing a little bit more, and obtaining more preliminary data. Hopefully you will have focused on a more specific area than the area you were working with your fellowship. And by focusing more in one area and getting guidance from your mentor, you're going to be able to transition from a career development award to a research award, which are basically the R01s. The R01s can be grants that are for basic research, for translational research, and for clinical research as well. But the NIH is not the only source of grants. You need to think that pharmaceutical industry also provides grants for research. So endocrinology societies also provide grants for research, Diabetes Society, for example. But the solid foundation is obtained when you get an NIH award or a VA award, for example. So what you're going to be looking at is spending your time in an academic setting, had a small time where you see patients, and a larger time when you do your research. If you're doing basic research, most of the time you're going to spend in the lab setting, in the laboratory setting. However, if you do clinical research, you will spend a lot of time in the clinical setting seeing patients. But the important thing is for you to understand that that big chunk of your time that is protected from the grant can be variable. And for example, during a certain period of time, you might have only 50% of your time protected because you lost a grant. Or in another time, you were very lucky and you got 3 grants, so you can protect a lot of your time. So during your career, you will be shrinking and expanding your research time, hopefully very large time, but you will always have some time protected to see your patients. That's basically what happens in the academic setting. Am I okay with time? So it's also important to realize that you never get rid of your mentor. That's maybe you should look at when you transition into a research career, you need to think that maybe you don't have a mentor, just the one that you had in the fellowship, but maybe you have a role model that you want to follow, or somebody you want to get advice from, somebody that's going to introduce you to different awards in your career as well. So it's very good to keep a good contact, a very close relationship, maybe with your former mentor or with mentors in another institution, but it's also very important to keep somebody that you can go and talk to and get advice from. And as time goes by, you will see that you will become a mentor for those young fellows that are training. So obviously, if you're doing research, you need people to work, right? I mean, you're working, but you also need the fellows to work. And that's very rewarding to see that you can become somebody that can attract young people to your program and mentor them into the same steps that were very successful for you. So, the clinician educator is somebody that really maybe doesn't want to be stressed with competition, with grants. I have to say, this grant thing is something that's very stressful. It's very hard to get those grants. But, so you can still be very active, playing a role with the fellows, but in a different role, in a different setting, much more of an educator than as an investigator. So this is a very tough track. Institutions normally don't give a lot of these spots away. Why? Because you will be teaching someone, and you will be getting paid by the institution to teach somebody, but you're not going to be generating cash for the institution. So they look at you, and they when you don't have grants, the hospital looks at you and they want to see this, right? And because you're so good at teaching, and because you have your mentors that are cleaning away for you, you have this time protected. This time I just put 50%, but you could have 5%, then next year you can have 10%, and as time goes by, you're building your protected time to be an educator. It's very, very rewarding. I see individuals in my division and in other divisions as well that shows that pathway, and they're very happy because they really convinced the institution that they deserve a chunk of their time protected while they're not being productive dollar-wise for the institution, but they are taking the mission of the academic endocrinology forward for the institution. And finally, I think that that's maybe the entry point. Let's say you really don't like fellows. You don't want to talk to them. You just love your patients. You just don't want to be involved in anything. You don't want to fill reports. You just want to go there and see your patients. And you want to go to grand rounds once a week. You want to meet people, but you don't care about educating. You have your family. You have other, you will be surprised on how many different interests there are out there when you start talking to people. And you can be working in a clinical setting, seeing a bunch of patients. In that case, you will be very familiarized with a number that's called, something that's called RVU, which is a unit used to measure your productivity as a clinician. Just to let you know that there's a national standard for RVUs. Usually institutions accept that you're in the average meaning you're 50th percentile nationally. Last year, the 50th percentile was 4,150 RVUs. That means that you're working towards a goal, and your goal is to get that number. It means that if you get to this number, the institution says, fine, you stay there, I'll pay your salary, maybe I'll get you a bonus if you go a little bit above that, but, the whole time you're there to see patients. So, I'm sure you can find hybrid situations in these three different tracks, even though the second is already a sort of a hybrid situation. But I think that if you look at academic endocrinology, academic thyroidology, this is basically what you're going to find, that those are the options you will have facing you. But if I can give you one advice, the most important thing is the mentor. Because you don't know any of that. You don't know how to take those steps. And the steps towards different tracks need to be guided by a mentor and customized for you. Thank you. Those are what I wanted to say.
I'm Elizabeth Pearce. I'm from Boston University. I have no slides. This is informal. I'm hoping this is going to be very interactive. And Tony is an example of somebody who's an academic thyroidologist whose background is primarily in bench research. I am somebody who is an academic thyroidologist, and I really have no background whatsoever in bench research. I've never done it, really, even as an undergraduate. I do clinical research and epidemiologic research. So I'm here to give you just a flavor for a slightly different version of the academic research track. And I sort of got to where I am by a way that's becoming a little bit more standardized. I think a generation ago, 10 years ago even, it wasn't so clear how you got to be a clinical researcher. There were no real training programs in place in most institutions. And when you're at the bench, you learn from your mentor, and it's pretty hands-on. I mean, you're going to learn specific scientific techniques, and you're going to learn it from somebody in the lab, and they're going to teach you until you get it right. And what, the techniques you need are going to be based on the kind of research you're doing. The same is really true in clinical research. You really do need techniques, and you really do need to be taught, but it's often a little bit more nebulous. You're not hands-on in the same way. You don't have a specific, way you're learning to pipette or to run gels. What you need are things like study design, epidemiology, health services research, biostatistics, again, kind of depending a little bit on the flavor of what you're doing. And those are things that are a little bit hard to pick up on the fly. At least for me, I don't think those are techniques I would have been able to learn without formal training. And I think the NIH sort of recognized that about 15 years ago when it realized that there really is a need for taking science from the bench to the bedside, and that there weren't a lot of people in this country with the formal training for techniques and how to do that. So there are programs around the country funded by a mechanism that's called K32. They're institutional-based programs. They may be at your institution, they may not. They're scattered in different places. I was lucky enough to do my endocrine fellowship at Boston University, which has one of those programs in place, and I'm actually now on the faculty of that program, so that concomitantly with my endocrine, 3-year endocrine fellowship, I also did a 2-year fellowship in clinical research that was funded by that K32 mechanism. And as part of that, I did a Master's of Science in Epidemiology, which again is, I think, really useful to have some sort of formal training mechanism for those kinds of techniques that you can't pick up on your own. So biostatistics, epidemiology, health services research, again, there's sort of different flavors for this. There are different kinds of programs for this. It doesn't have to be a degree program. But I think often if you want to do some flavor of clinical or epidemiologic research, in order to get funding down the road, in order to make that first step to a K grant, it's helpful to demonstrate that you've at least taken some steps down that pathway. The first step after finding a mentor, and I would really echo Tony that that is the most critical piece of this whole process, is to sort of identify your area of interest and maintain mentors. I think forever, certainly as far as I've gone, and I think for a lifetime. And it may not be a single mentor, it may be other mentors. As I'm progressing in my career, I'm finding that I get mentoring from different sources. And some of it's academic, and some of it's sort of more work-life balance kind of mentoring. But I'm finding it in different places. Venues like the American Thyroid Association are a wonderful place for sort of informal mentoring, people at different stages of their careers. The first step in a clinical research academic career often is a K grant, as it is for a basic career. But the flavors of the K grants are a little bit different. So if you're doing one that's more basic, it's a K08. If you're doing one that's more clinical, it's a K23. If you're translational, you may be somewhere in between, and you sort of pick the mechanism. They're similar in terms of the application process. They're pretty much identical. But obviously the flavor of research is a little bit different. And certainly, I know for K23s, and I suspect for K08s, but I don't know as well, they are becoming much harder to get. When I did it, I wrote my K23 in my 3rd year of fellowship. I was funded July 1 when I started as a junior faculty member, and that's really not happening very much anymore. Since I did it, which isn't even that long ago, they've really tightened, I think, the funding for these career development grants. So it's really good to start planning what you're doing, perhaps, the third year of your fellowship. But I think it's more typical these days for them to get funded a year or two out. So you really need your mentor to go back to bat for you with your institution and create some protected time for you up front. And again, that's getting harder to do as institutions are getting squeezed for money as well. But often the K grant is getting funded after a year or maybe after 2 years out of fellowship. And so it remains an option. But I think the goal is to work with a mentor, come up with a time plan, and hopefully have some publications before you apply for the K again because they're getting tighter, and that's a helpful thing. I don't really have anything formal, I think, beyond that, so I'm going to turn it over to our next speaker, and then hopefully we'll have lots of questions at the end.
Well, I didn't go back and forth to Brazil. I just traveled all over the United States, so I've had a little bit of a crazy career, too. I actually started in my fellowship in basic research in insulin resistance and then clinical research in hypoglycemia, but I really love taking care of patients. And so I went into private practice. My husband's an engineer, and there's a shortage of endocrinologists everywhere, so it was easier for me to move with him when he needed to move. And because of that, I've had quite a variety of practice experiences, from solo practice to group practices to employment by hospitals to back to solo practice, and in different parts of the country. And one thing, I love taking care of patients. I love being part of a medical community. I've always loved being part of like a team taking care of patients. And I've always had incredible respect, especially for the endocrinology community, because we work so hard to tie together our basic scientists, our clinical scientists, and our clinical practitioners. And my hope and dream for the American Thyroid Association and for the Endocrine Society and all of us is that we can continue that, that keeps all of us strong, and that we can continue that respect for each other. The basic scientists are worthless if they're not really helping mankind with all their science. And we atrophy and shrivel up if we don't have the input from the clinical and basic scientists. So that's always been a wonderful part of endocrinology. And even though I went out into private practice and not into academic patient care, I've continued to send patients to studies. When they were studying McCune-Albright at the NIH, I got tissue from my patient with McCune-Albright who'd had surgery and sent it to the NIH because somebody there needed specimens. I'm hoping within all of our organizations that we can increase, if anything, the awareness of what kind of studies are out there to help patients. Even though I lived in Atlanta for a long time, I'm now in Colorado, I send a lot of patients to a study in New York on idiopathic premenopausal osteoporosis. When I was in Indianapolis, I sent a lot of patients to the NIH for studies on acromegaly and on thyroid cancer for what's now called Thyrogen. I had something like 12 patients in Bruce Weintraub's study looking at what is now Thyrogen. So just because you go into clinical practice, you don't have to not participate and not be connected with the wonderful science that makes up endocrinology. And because I've always liked working as a team so well, somehow I've evolved into working on models of healthcare. So now I'm working within the American College of Physicians as well as endocrinology, and getting bigger, working with all other surgeons, OBGYNs, on improving our care coordination and communication. So going into private practice doesn't mean that you're going to isolate yourself or sever off all the things that are make endocrinology wonderful and make the learning and the interaction wonderful. So I'm sure you'll have questions about private practice. We all have questions about private practice right now. Everything is molding into different models, and that's why I believe so strongly we as physicians need to stay at the table, because otherwise somebody else is going to mold it for us. So
Okay, so my name's Jim Magner, and I'm the fourth and final speaker, and then we'll have questions. So I work in industry, and this is probably an area that's least known to you and perhaps of least interest to you. But I wanted to balance that because most of the examples of day-to-day work that you're familiar with are in the clinic or in academia, because that's where you've lived your life. And so industry is a little bit foreign. So I wanted to just make a few introductory comments. This is a bit of a scary time, I'm sure, for all of you, because you're very excited about, achieving what you're achieving in your fellowships and going out and getting a job or advancing your career. But of course, there are many challenges in academia. You've heard the faculty complaining. There's, problems, budgets, and this and that. In private practice, with insurance, arguing with insurance companies and this and that, there are problems. And in industry, we've had our problems also. I mean, it's with drug shortages, with increased regulation, and with perceptions of industry. So what is it really like working in industry? The one concept I wanted to make sure you knew is that just like in as Tony was saying, in academia, there are like different sorts of positions. In industry, for endocrinologists, there's sort of three basic different sorts of positions. One is to actually be sort of a physician scientist. As you're writing protocols, working with external experts to write protocols and study a particular issue, such as doing a phase 2 study, a phase 3 study for a candidate molecule that may ultimately become a drug. So that's like a physician scientist, and it's very similar to clinical research, except in a more regulated way. We're on the other end of the clinical research in many ways. A second type of role is medical affairs. So that person doesn't develop the drugs. That physician is basically, his role is to interact with experts and with practicing clinicians to help them use the drugs that are on the market properly. And so a lot of that physician's time is having advisory boards, helping to organize speakers bureaus when doctors go into communities, the speakers have to have slides. The slides have to follow certain regulations and rules. They have to be a certain, follow the label of the drug. And so that's a whole different role, though, than actually trying to figure out how should we, what measurements, what blood tests should we draw, and how many EKGs should we do, and this and that, to develop a drug. So medical affairs is more interacting with customers, explaining what's on label. But a medical affairs physician, unlike a salesperson, if asked, can also explain off-label uses of the drug. Whereas a salesperson is really never supposed to speak about off-label uses of the drug. Okay, and then the third role in industry is in the safety department. So you could be an endocrinologist, get a job in the so-called safety department. Many places it's called pharmacovigilance. And there are, when a drug is marketed, doctors may be seeing certain sort of unexpected things that are happening. Skin rashes that seem to be more frequent. Somebody drops their platelet counts, and then it finds out in another state a patient was treated with this drug that supposedly seems to be very safe from the 3,000 patients studied in clinical trials. But when you release it to 2 million people, you start seeing the less common side effects. And nobody really knows whether an individual patient's drop in their platelet counts was due to the drug, but if there's a post-marketing surveillance where you're starting to gather that information, you find that out. The safety physician also helps to analyze in the clinical studies during drug development adverse events that occur in those studies. But if you have 300 patients in a study, and then you have various things that happen, hip pain, headaches, that sort of thing, with 300 patients exposed to drug, you can only reliably detect adverse events that occur usually at greater than 1% probability. So anything that occurs, let's say, 1 in 1,000 instead of 1 in 100, you won't reliably detect if you only have 300 patients exposed. Anyway, so those are the three main categories. In wrapping up, and then we'll get to questions, I wanted to explain about how to get an entry position and just a few final thoughts. Most most companies have web applications now for jobs. So you would go onto Merck, Pfizer, whatever, look over the job postings that are available, read the descriptions, and then of course it would help if you have some expertise in the area. If they're looking for an endocrine development person, the strongest expertise is if you already worked at another company and you're just switching between companies. That's actually very easy to do in general in industry. Once you can get into industry, then, and you have some experience, you can switch around. Also, within a company, if you start in a safety position and you're doing a good job and knowledgeable, but then after a period of time you wanted to switch to a different role, you can switch to one of the other two roles if a position is available. What are the advantages of industry? Well, I've worked with medical students and then with fellows over the years, and people have been stressed, a little flustered about various things. They maybe have a serious personal relationship, and then they're deciding to move, or should we get married? How can I make money? I need to save money. And money is very important. So money is very important, and there are implications if you go into academia or private practice of different types, or into industry with different roles, and so that's a consideration also. I decided that I would write up, I'm near the end of my career, sort of a case study of how I find my way through my career. And so that's what this handout is. I have a hobby of collecting quotations, so the first page are just some interesting quotations that I collected in the last few months, and every year I'll pass those out. Another page shows the table of contents of my case study, which I'm not going to go into any detail right now in case, unless somebody asks about it. And then the book, because my hobby is chess, and it's very important that you maintain interests outside work, whether it's skiing or chess or some other hobby that you have. And of course your family, your career, your family, and these other interests are very important. I made a list of some of the advantages and disadvantages of working in the pharmaceutical industry, which you should look through. I've had other people look at them, and they say those are pretty accurate, advantages and disadvantages. And then I made a reading list, okay? And of course, if anybody would like to buy 50 copies of the book, and it makes great holiday gifts, then go right ahead. But on a serious note, you need to consider industry as a possibility, in addition to clinical practice and the academic parts, because we need good endocrine experts in industry, and there's not as many of them as we need. Just like clinical endocrinologists are in demand. There's a demand for endocrinologists in industry because of all the emphasis on type 2 diabetes, coronary heart disease, and the metabolic, relationships to that, and to some extent in recent years with the kinase inhibitors for thyroid cancer and all that. There's been a lot of effort in endocrine in industry. So let me stop there, and maybe we should have questions for the group.
Please tell a little bit more about different types of private practices and versus the hospital-based, and just to give us some brief review on that.
Okay, can everyone also just introduce themselves again? They didn't catch everybody's name maybe in the beginning, they're saying. The question was sort of if Carol could discuss some of the different models of private practice.
I'm Carol Greenlee, and right now I practice out of Grand Junction, Colorado. I moved to Colorado to be close to my family when my husband went to work in Wales. Before that, I was in a setting in Atlanta. So right now I'm in private practice, solo. I have to rent my space. I have to pay my employees. I have to get their benefits. I have to get my own EMR, so there's a good thing about that. When you're in an institution, they get all that, they do all that for you. the bad news is they do all that for you and you don't get much say. When you're by yourself, you have to figure it out by yourself, but you get to choose pretty much what you want. Sometimes it's what you can afford. I've been in so many different practice settings that I'm very comfortable, and I'm also a lot older now, so I'm very comfortable being in solo private practice, and I'm in a community where they're just thankful to have me there. So when I come here, nobody's yelling at me that I'm not there on call or something. So every community is different. When I was in Atlanta, I was part of a big group practice. We rotated call. We had formulas for how we split up the money. Sometimes it's always on your production, and I always try to get it on my production if I can. So if I want the option to go to more meetings or to take more time with patients, it's not somebody necessarily driving me, as opposed to if they're paying me a salary and they expect almost like the RVU thing, but in private practice. Whereas do you know what I mean by production? Okay. So I always preferred that model. Very common, many years ago, was for hospitals to buy practices and hospitals to own the doctor's practices. So in essence, you're a hospital employee. That fell out of favor with all the economic turmoil. A lot of doctors are going back to the hospital. And it's interesting right now, a lot of the doctors, the specialists who have earned more money are going back because they're afraid that some of their income sources are going to diminish. And some of it's a big problem. So a lot of oncologists and cardiologist groups are being purchased by the hospital. I think if you're in an academic institution, that there's not as much arbitrariness as can happen in a private hospital or some of the not-for-profit hospital settings, where they sometimes, whether they keep you or don't keep you isn't based on the normal rules. So, and some are good about that and some aren't good about that. Or what they expect you to make is less well defined in some of the hospital employment, and it's caught some people by surprise. They've thought, oh, I've got a guaranteed salary. I can not work as hard. And then at the end of the year, they kind of get punished almost. So if you go into a setting like that, which is more secure when you're first starting, just make sure that you understand that they are keeping track of the overhead and how much you're bringing in, and find out what your expectations will be, because I've seen people come into those kind of employment where they thought they could take it easy. And then at the end of the year, they said, okay, well, next year we're only going to pay you what you brought in this year, which was a huge reduction. So just kind of being aware that math is involved. But mostly you don't walk around thinking about that. You don't walk around thinking, how much am I making? What are they keeping score of? You walk around thinking, how can I take care of this patient? You interact with the other doctors in the community. A lot of primary care doctors you interact with. They call you. They look to you for guidance. I do both peds and adult. I don't do the growth and puberty thing. I just do the thyroid and diabetes. So I get to work with pediatricians, OBGYNs, primary care, internal medicine, surgery, all the other subspecialties. And so even though you have to pay your own bills, et cetera, that's not what you walk around thinking about most of the time. I would say that the absolute worst thing is employees, okay, and dealing with employees. And before I left, my 2 employees had a huge fight with each other, and I was trying to get my charts done. But when I talk to people in the lab, sometimes they have trouble with and how to deal with employees, because we go to medical school. We don't go to business school, or I don't know what that is, administrator school, whatever kind of school you go to deal with employees. And when I talk to my friends at academia, they say that's sometimes, the clinic staff, the whatever staff. So you're going to have, I don't know how it is in industry. I think you said one time that's, you guys have.
Yeah, we never have trouble.
Right. Right. So that if you don't want trouble with employees, but I think the rest of us have trouble with employees. And I'm not sure I've answered your question, but there's private practice groups where you can go in on a salary and the group pays you a salary. You can be employed by a hospital. The hospital pays you a salary, but some hospitals will let you do production. Some groups like production. Some groups you do all your own call each night, and on the weekend you share call. Some groups you rotate the call every single night. There's solo practice. There's multi-specialty groups where you might be an endocrinologist, but you're part of a big group where there's also a rheumatologist, 5 cardiologists, and 25 primary care doctors, or maybe not that big. So there's all kinds of models out there. All of these models are probably going to be changing as we're being encouraged to become more integrated, but I'm not sure that's a bad thing. We just have to see in different communities how it folds out. I live in a very independent-minded community. We have an IPA, which is Independent Physicians Association. So we're trying to integrate and still remain in private practice, not all become employed physicians. Other community organizations are coming together and employing all the physicians in an integrated system. So depending on your mindset, and again, we don't know what's going to work. This is all new all around the country. So there's communities like ours where the independent doctors are joining together to try to stay independent but work together. So you guys are coming out right at a time as a lot of things are changing, and we're trying to make sure they're changing for the better. So probably get some more questions.
So I kind of it's sort of almost like a political question that maybe the academic people and you could sort of co-answer. So I'm finishing a 3-year research fellowship, but I'm taking a private practice job, and that was mostly because I wanted to see patients, but also because of family limitations and location. So I've sort of come up across a lot of negative feedback kind of from the people in my division, and it's made me a little concerned about what will happen down the line if I decide that I want to do a job that incorporates some teaching or work with a fellowship program or something like that. And can you go back once you've gone into private practice? Is it really difficult to do? And maybe just how to deal with, if someone kind of has a negative look, even just a look when you tell them is like you told them that you were, I don't know what, doing something really bad, like going to jail. So one of the things that there is not are mentors for private practice. And most of the people that you're going to talk to in your academic setting have never been in a private practice setting. And there's that old town gown thing, which fortunately is getting less and less, at least within endocrinology. Okay? So, but one of the things that we're aware of is that the people that you go to for your advice most of them have never been in private practice or in industry. So they might roll their eyes at industry too. The going back, I can't answer the going back, but I actually thought about going back until I needed to go help with my parents, And I think maybe it depends on how you've gotten to know people in your organizations. Have you been on committees? If you've seen they're doing a research, have you called them and said, I have patients do you still need patients for your study? Or when I was in Indianapolis, I stayed very connected to my university. Even though I went into practice, I went back to Grand Rounds. I stayed very close to all the people there. So if I wanted to go back, at least there was an opening. Now, on the other side, they may have said, we're not taking you back. I don't know. And you guys will have to answer that.
So keep in mind that, all of us in academia and all of us probably in practice and industry, we're all trying to sort of create trainees in our own image. That's part of the gratification of mentoring. So part of the reason your mentor may be rolling their eyes is because you don't want to do exactly what that person is doing. And you have to just take that with a grain of salt. I think certainly it's not it's probably more common to transition back and forth between academia and industry than between academia and private practice. I think it's not unheard of to do any of those things, and I think people's career strategies are very variable, and they may involve moving back and forth from country to country or doing somewhat non-traditional training steps, and that's, the more you ask around, the more you'll find that there are a lot of different flavors of this. I think it would probably be easier if you're moving from a private practice kind of setting back to academia to get a full-time clinician or possibly clinician educator role than a research role where there's sort of a track where if you get off that track, I think it's a little bit difficult to get back on.
There's a brilliant researcher in the osteoporosis field named Cliff Rosen who started out as a primary care physician and then became an endocrinologist and then went back into scientific research. So I would say exactly what you said. It's not impossible. And he started out, I'm pretty sure, as a primary care physician, and he's absolutely phenomenal in his bone research. So I wouldn't put any limitations on what you want to do. I think passion and drive are probably more important.
Right, absolutely. I think that if you did a good job and you had to leave for family reasons, everybody will understand that. I mean, and if somebody that did a good job calls back the former boss and say, I'm coming back town, can I, do you have an opening for me? If he remembers you that you did a good job, he's going to say absolutely yes, or he or she. Absolutely. I have a question for Jim. So, if you're part of a private practice and the majority of the owners decide to fire you, you're gone. If you're part of the academic setting, however, it's very, very difficult to get somebody fired. I'm division chief. I look at my faculty. If I want to fire somebody, it will be almost impossible for me to fire somebody. So, and I think the big danger, as I look at the pharmaceutical companies, is that you can be fired in a snap. So, can you elaborate on that? How does that work?
Yeah. Well, first of all, I was in academics also, and if you want to get rid of somebody who's not doing a good job, I mean, you give them a smaller office, you give them, all sorts of, hurdles and things you can put in their way, and you laugh, but this is actually what's done. And eventually, they don't get raises. They have other, chores they have to do for committees and this and that, and then they have to do the Saturday, whatever it is that has to be done on Saturday mornings or something. And then eventually, they want to find another job. Now, it depends also whether it's a state school or a private institution or whatever. And it's the same way with pharmaceutical. Louder? Okay. In industry, in different countries, there you have, for example, in Europe, you have 90 days notice if either you want to quit your job or if the company wants to fire you for whatever reason. So it's 90 days, and that's based on European labor laws. My contract, when I've worked for two companies, Bayer, the big German company, but had a U.S. branch. And now for Genzyme, we have what's called an employment at will contract. And it means that if I decide that I would like to quit, I need to give 24 hours notice. And then I could quit in 24 hours, although usually, as a courtesy, you might say I'd be willing to work the next 2 weeks to help transition. The way that an employment at will contract works, though, also is from the other side. Is to protect the managers that there's not this 90-day European-style thing. If the project that you're working on gets canceled or there's some other big change in the company and they have to change for the shareholders, change the dynamics of the spending, they could tell me, Jim, we love you. The last year, you've done a great job. You've done everything right. However, due to circumstances beyond our control, Friday will be your last day. And that's true. That can happen because of the big drug they're working on in phase 3 fails, and suddenly, or a drug that's marketed has a major, new side effect, and it has to be changed or withdrawn from the market or something. And there are real examples of that. The thing is, what you need, my last comment here, and we need time for other questions, is, as I put in my handout, of course you need a good mentor, but you also need to know yourself as you think about this choice. And you all think that you know yourselves, but it's possible that you may not know yourself still fully yet, because you all look young to me, okay? So I made some suggestions in there that I've used with medical students and fellows through the years about how to think about what area you want to go into. And then you need to, without making rash decisions, you need to go with your gut and actually go ahead and sign up for that private practice job in Indianapolis or whatever you think that you would want to do, even though you're not 100% sure that's the right choice. But then when you make a choice, you need to commit to it and believe in the pursuit of excellence. You can't solve all the problems in the world, but what you're working on that hour, just in that next 60 minutes, you can be the best effort that you can make for that 60 minutes. And of course, after that, there's the next 60 minutes. So in other words, every day, you just believe in the pursuit of excellence and do the best you can. And then if things are not working out, don't make rash decisions, but after an extended time that is appropriate for you and your family, if things are not working out, make a change. Move to Colorado or someplace like that, or change companies. And but you need to be, my other piece of advice is financial. You need to build up savings by not going out to eat as much as your neighbors do, by not buying the new car every couple of years. Put the money in the bank so that if you don't like your situation and you're not making a rash decision, you have those funds in the bank that you've decided that, if they don't meet my conditions, that I don't want that clinic on Saturday morning, and I'm not agreeing to do it. And if they say, no, you have to do that, then you say, well, I'm going to have to write my letter of resignation. And I've described in my own case history a couple of times when I had to do that. And so if you have, and nobody wins the lottery, so the way you build those funds are by saving a high percentage of your salary, every paycheck, save a high percentage, and then invest that wisely so that it can grow, and then it gives you the financial power that if you're not in a situation that you like, then you can change.
For understanding how to code, or so, okay, are you planning on going into solo practice? Okay, so the billing thing you need to understand, but you need to understand the exact same thing if you're doing the clinic. Well, I think, do you guys code for your own patients? Yeah. So the same diagnosis codes and E&M codes, and if you do, a thyroid biopsy, a procedure code. But I'm in solo practice, and there's a lot of solo practice people, these independent-minded people in Colorado, okay? And we use a billing office, because it's hard to keep up with all of endocrinology, and then we have to keep up with all the new drugs, and we have to keep up with the rest of medicine because our patients are, and then you have to deal with your employees, right? And you have to keep up with the billing and coding and now meaningful use. And so not to cop out, but I would focus on your aspect of it, which is the coding and charting part of it, and let someone else deal with all that billing stuff. And if the problem would be if you're going to go in solo practice and you want to do it all in-house, and you have to make sure the billing person is not embezzling from you and all of that, that gets to be overwhelming. But I would focus just on the stuff that you're probably already starting to learn as fellows. But do they learn it at all? And the American Medical Association has things. ACE has something, but I don't know what's happened to it, and it had some problems with it. So I actually don't know where that is right now. But there are places where you can go to get that kind of thing. But the billing thing, honestly, I'm going to just say outsource it.
I'm sure you're going to find different institutions with different guidelines, but in most cases, I would say that if you're in an academic setting, you're encouraged at least to be doing some sort of research or participating, maybe not necessarily as a principal investigator or the leading author of the study, but you can collaborate, by actively finding patients for that study, so forth and so on. The point that you are making is whether or not you're going to be happy being an assistant professor for the rest of your life without doing research. And I think that you will find that a lot of individuals do find, a very satisfying and gratifying academic life being an assistant professor. Just being co-authors of different authors don't necessarily have the drive to be the principal investigator or the leading PI and here and there. And is there a room for those individuals? Yes, absolutely. I think there is. There's need for endocrinologists in general, but in academic setting as well. So I think I like the academic setting because it can be, it's not one size fits all. If you have a good understanding with your boss or with your mentor, your career or your time at the institution can be customized for your interests and vice versa.
Yeah. Well, I'm going to ask Elizabeth or Tony to answer. How, I guess, as people who are primarily researchers and I see patients. Do you see patients as well? Yeah. So, I think, how much time do you think you can really spend seeing patients and then still also be able to do meaningful research, which is a time-consuming thing, and I think that's one of the very hard things in academic medicine.
I think if you're really trying to do research, the majority of your time really needs to be on that. And I think if you're doing, 50% clinical time, that's probably enough so that it's very hard to maintain, I would think, a clinical program. I think typically a 20 to 30% clinical commitment, or even less, depending on how well you're funded, is usually ideal. For me, seeing patients, I'm currently not well funded, so I'm currently up to 40% clinical, which is the most I've ever been. But for me, 20% clinical time was a really nice mix. It allowed me to feel like I really had competence and could enjoy seeing patients, and I do enjoy seeing patients, but really left a lot of protected time. Even though I'm not at the bench, I spent a lot of time sitting in front of my computer screen, and that's time I really need to focus. I think surgery, and we don't unfortunately have any surgeons up here today, is a little bit harder in some ways because you need a certain amount of surgical volume to be good at what you do. And I think that's a different mix, and I think that's probably advice that would be best from a surgeon because it's, I think, very different from clinical medical patient care.
Just, Tony, if you could just say your mix of what you do.
Yeah, I do 10% clinical and 90%, 10% clinical, 25% administrative, and the rest research. And I agree with what Elizabeth said. You need to have the bulk of your time dedicated for your research because you're competing with people of all kinds of people at the NIH, and you're competing with people that are doing 100% of their time in research. So they're really good at what they're doing, and the physician scientist has to equilibrate everything. So you need to put some time into the research. One aspect I didn't mention when I was talking, and then Jim mentioned something and it came to mind. The good thing about having your grants is that you do have a great deal of flexibility of where you want to work. If you are well funded, you just pick up the phone and you can go anywhere you want because when you go, you bring your salary with you. And that's it's a great thing to have so you're not depending on the institution completely. If you have 50% of your time, 60% of your time, you basically call Colorado or call whatever you want and say, listen, can I go? I really want to move and I have my grants and I'm going to pay 60, 70% of my salary. Who's going to say no to that? They couldn't care less about that. They're going to fund the best research they can. They might look at, if somebody has an MD, a PhD, or an MD, PhD, or whatever, they're looking at the grant, they're looking at the PI as well. So, let's say if you have 90% of your time is clinical and 10% research, but if you really have a good grant, I don't think, I've never seen, I've been at the NIH for 5-6 years, I've never seen anybody say, well, this is a great grant, but there's too much time clinical. No, they're looking at the proposal, they are looking at the data and the proposal, and they're going to fund it the best one they can. And the physician scientists are in a tough spot because it is recognized that they don't have all that time that a PhD has. That's right.
Well, it's the time when they find out there's an endocrinologist in town. It's hard not to start out too fast. If you're going to join a group, that group may already have established the hospital rounding type of thing. And some endocrinology groups don't even go to the hospital very rarely. The hospitalist, somebody comes in the ER and DKA, the hospitalist admit them. And every once in a while, you're asked to come and see something. Others have regular rounding. They have lots of patients. They admit their own patients to the hospital. Or when I was in Atlanta, I was part of the liver transplant team. I was the liver transplant endocrinologist. So I had those. I did a lot of other strange consults, like hypercalcemia consults, not as much as the diabetes consults. So it's probably going to be a little bit regional and group specific. Some of the groups I've talked to don't go to the hospital at all, which I find a little bit amazing because sometimes they still need help. There's always the pan-hypopit patient who comes in with hyponatremia and some of those kind of things that you hate to miss those cases and not help with those cases. What we're working on nationally is improving the referral process, and I'm going to talk about that a little bit tomorrow in my Meet the Professors, but these guys probably are doing something tomorrow, Stephanie? Okay. So we're working on and trying to improve that, to try to get the referrals more appropriate. But what I do is, and it's a lot of work, and my husband, the engineer, thinks I'm crazy, but I read through the records ahead of time because I can't always count on somebody knowing what's urgent. And I've picked up lots of really sick hyperthyroid patients that were sent in as routine or something else. On the other hand, they can put hair loss as urgent. Or I get sent all the time lupus and rheumatoid and things because they can't always keep straight. And right now, the way the primary care doctor refers a patient is that they tell their staff to make the referral. So then the staff can't keep endocrinology, rheumatology, or something else straight. So I really get referred a patient for endometriosis. I don't really want to see that patient. It's taken an hour spot. And I still give hours for new patients. People drive 4 hours to see me, Or I see the kids with new onset diabetes and I give them an hour and they take 2, So, I'm not going to give an hour spot to endometriosis only to find out they didn't need to be there and they just drove 4 hours, right? So I actually review the records as the doctors send them. The problem is if they don't send the records ahead of time. So in the beginning, you're not going to have limited space. Most endocrinologists, I think, still have kind of a wait to get in to see them, right? So you're gonna want to get the sickest patients in first. And how to best triage that? For me, I just took to looking through, okay, this is a type 2 diabetic with an A1C of 8.9. This is a new onset type 1. And then I have my staff trained pregnant diabetic, pregnant thyroid, certain things and then I ask the doctors, I get to know the doctors in the community, and I say, I have spots frozen every week. If you have something, call me. And
if they don't call me, I've got this pregnant diabetic, or I've got this bad thyroid cancer who's hypocalcemic since the surgeon did this and cut her vagus nerve and she can't stop vomiting. That one I actually saw in the hospital. That you would get that patient in, then I just move up the people on the wait list who sometimes I'll say not urgent, but put on the move up list. So they're not quite qualifying as urgent. So it takes some investment on my time, but I feel better doing it that way because in endocrinology we do usually have a wait. But when you're new and you're just trying to fill up the space, you don't have to. It's mainly going to be what you can do as a new doctor. I've been in practice a long time. So when I moved to Colorado, I just booked solid. I knew how to see patients. I knew how to dictate. I knew how to do all of that kind of thing. I knew how to code. I knew how to draw my pictures, explain everything, But as you're starting out, how full are you going to want to fill your schedule so you don't keel over? On the other hand, how much of a break are they going to give you? And that's why we try to give people a salary the first year. You just don't want to take advantage of that so that they feel that they're getting, ripped off. I had somebody in Atlanta who saw a patient, booked a half hour to dictate, saw a patient, booked a half hour to dictate, okay? And I wasn't paying her, the hospital was. She just came into our group, and at the end of that year, she went home crying. The day when they talked to her, she went home crying. I don't know exactly what they said, but it probably wasn't real nice. It does. Well, sometimes hardly anything comes in and it's real easy. It's a little piece of paper. Sometimes the doctor calls me. Sometimes there's a huge stack, and that happens to be a day where I'm busy. And I kind of just look through to see, and we actually made up a referral form so that I can see right away what they're referring. So I can't say every day I spend a half hour on it because some days it actually takes more and some days I don't do it at all because it took me 3 seconds to look through what came in. So I know that's not a very good answer, but.
We're actually out of time.
So you guys can look for us. Look for any of us at the rest of the meeting, and we want to help you.